Yes, we back at it. Ladies and gentlemen, welcome back to our international ground rounds. Once again, really pleased to have a friend and colleagues from Johns Hopkins University. Welcome back, Nicholas Rowan. How are you?
I'm doing great. Thanks for having me today.
So, Nicholas and I had few other session together. Today's, I think that is very interesting to see what one topic specifically, like olfaction, is getting a lot of attention for you searching through the platforms and the internet. Olfaction became much more interesting topic last 2-3 years because of this pandemic. But there's a lot of other origins and symptoms and disease related to olfaction. And what we are going to analyze today, Nicholas is going to show you how much could make an impact in daily life, especially in some certain subjects. So as you know, if anyone has some questions, please type it and we will go and we'll reply all these questions at the end of Nicholas' communication. Please, Nicholas, share your screen.
Awesome. Screen looks okay.
Let's see. Share it again. Yes. Perfect.
Beautiful.
Thank you.
You got it. Well, thanks for having me. And I agree with that introduction. I mean, the timing of olfaction in at this moment in history is really pretty unique, given that there already was an increasing kind of groundswell going, of increasing interest in the sense of smell. And then we're hit by this giant pandemic that has a unique symptom that causes the loss of smell. And so a lot of my research is related to the sense of smell and aging, and specifically the relationship between olfaction and frailty. So I'd love to talk to you about some of my thoughts today and kind of the way that I try to analyze this over, over my research career and managing my patients. And so I don't have any really relevant disclosures. I am an awardee for by the Johns Hopkins Older American Independence Center. I have some money that allows me to focus on doing some of this type of research and buying some materials to carry out some of the studies that I'll present to you. I have some non-relevant disclosures. We host some clinical trials for chronic rhinosinusitis. I have a North American Skull-Based Society Research Award. But incredibly relevant is that I am highly biased towards the sense of smell. And so the objectives of this talk really, again, it's a little bit kind of going through my thought process of how this works. And I want to present a body of work to the audience today, knowing that we have a wide range of attendees that really makes a logical story. So first, I'd like to go over just olfaction as a primer, kind of how it works, why it's important, the basics. Some of this may be very kind of intuitive for many of our audience members, and for others, it may be a little bit, there may be some new information. I'd like to talk about what we have learned about olfaction and frailty and how this sensory process works with the concept of frailty, kind of what questions I'm currently asking, and then understand the implications of olfactory loss and frailty and how you might be able to prevent or even treat them. So going into the basics, well, the sense of olfaction is an evolutionarily ancient sense that's made possible by cranial nerve number 1. As many of us know, it happens in the specialized neuroepithelium in the olfactory cleft. That's high and deep up in the nasal cavity. As any of you have tried to biopsy the olfactory cleft for a variety of different reasons, whether you're taking out a tumor or not, it is, although this we commonly think of it kind of coating this entire area, it is a bit heterogeneous in this sinus nasal mucosa, but it is largely characterized by occurring in the see, my laser pointer here works, in the olfactory cleft, so high up against the cribriform plate, on the nasal septum here, and on the medial aspect of the superior turbinate, sometimes even on the middle turbinates. The olfactory nerve is really unique in that it's the only nerve that's directly exposed to the environment around it. And it's got unique direct access to the central nervous system. It has also a unique property in that it has a regenerative capacity, and it is has demonstrates some neuroplasticity. So you can actually make it stronger, and things change over time. So immediately on the other side of the paranasal sinuses and the nasal cavity sits the olfactory bulb. So it's kind of direct access to the central nervous system, which is very unique and compelling, and I think probably drives some of the unique associations that we see with this sensory function. Olfaction, many of us know this as well, kind of how the sense of smell works. Well, two different ways that our sense of smell works. There's two different routes by which we can smell. The first is through something known as orthonasal olfaction. So that's the ability to detect aroma or sense travel through the air into our noses. It's transmitted up into our olfactory bulb and olfactory cortex. The other way of detecting sense of smells is through, or detecting scents, is through retronasal olfaction. So that's typically when we're eating or when we're breathing through our mouths. And when we detect smells this way, the sense, the odorant or the smell actually starts in the mouth, travels up through the nasopharynx to the back of the nose, and up into the olfactory cleft, and then continues along the same way it would with orthonasal olfaction. And this type of smell is really interesting in that it actually accounts for a lot of what we, in lay terms, describe as taste. In actuality, this is probably the flavor of foods that we're experiencing, but it's certainly a large portion of what we perceive as flavor is not actually from our taste buds or the unique sense of taste, but rather from our sense of smell. As many of you know, when you have a cold or you get congested, you can't taste food as well. Well, nothing happened to your taste nerves, but in fact, you're unable to get air up to your nose to smell appropriately. And so, that's a nice way of thinking about it and understanding how the sense of smell drives our perception of flavor. There's a few different ways on how to test olfaction, which are really important to talk about. Notably, in the US, many of these are not regularly used in clinical practice. I would suspect that if there is some data available, we could probably see that things like the UPSIT, or the University of Pennsylvania Smell Identification Test, is more commonly used nowadays, that we've had an increasing number of patients with anosmia or smell loss following COVID-19. But things like self-report, which is the most straightforward way of assessing the sense of smell by simply asking somebody how their sense of smell is something that's easy to do. You can be a bit more rigorous, and you can ask a visual analog scale, which is a standardized metric from 0 to 10. Typically, it's a rating that patients can give their sense of smell. But like many things that humans do, it may not be fully representative of a person's true ability. We're not really great judges of what our sensory or bodily functions actually are. Then there's the psychophysical assessments, and these are kind of these are what I think of as the gold standard. So this can range from as simple as a scratch and sniff test, like the brief smell identification test, the University of Pennsylvania smell identification test. It can be a bit more rigorous, like the sniff and sticks, as demonstrated here. You can have a comprehensive kind of 48-item battery where you're smelling 48 different felt tip pens. And you can even test olfactory subdomains, such as beyond just identifying a sense of smell, you can test somebody's threshold, somebody's ability to discriminate different odors. But it takes a lot more time. There's some disadvantages of that. Meanwhile, there's objective olfactory assessments, which are typically just used for research purposes. Things like the electroolfactogram, EEGs, PET scans, functional MRIs. This type of testing, again, can be used for research purposes, but it's marred by a lot of false positives and false negatives, which generally limit its practicality for clinical use. So in summary here, again, really important slide for digesting the rest of the information that's going to come. Self-report is generally inaccurate or not necessarily reliable. Psychophysical assessments are the gold standard, and objective testing is really only used for research purposes. So I mentioned this on the previous slide when I was talking about the sniff and sticks battery. Olfactory subdomains, they're very interesting because at least a way of thinking about them is they may represent the peripheral functioning of the sense of smell, what happens at the level of the nose, versus the central functioning, what happens in your brain. And so identification and discrimination, those are complex tasks that require us to use kind of higher order cognition, executive functioning, and even our memory to determine, to distinguish one odor from another. And then even more complex, to smell an odor and actually be able to tell what it is. So the difference between if somebody gave you cinnamon and somebody gave you nutmeg, the ability to distinguish one from another would be your discrimination. The ability to say this is cinnamon would be the olfactory subdomain of identification. Meanwhile, threshold is a bit more of a basic kind of primary sense, and it's the simple ability to detect an odorant, to know that it's there. And it's the concentration level at which somebody is able to detect a particular sense. And so again, I think of this more as a little bit more of a peripheral measure of olfaction, kind of what's happening at the level of the nose or the olfactory epithelium. There are several different categories of olfactory loss and olfactory impairment. You can have a conductive loss. So in this patient, they had a mass growing in their olfactory cleft, which did not allow them to get odorants up into the olfactory cleft, but the remainder of their nose and presumably the rest of their brain was normal. Meanwhile, sensorineural loss, that's a direct insult to cranial nerve number 1. So for example, what we've seen with some of the COVID-19 research with the misfunctioning of the olfactory nerve, or potentially even age-related, as which we'll be talking about today, as the sensory function declines. Or you can have a central nervous system, a central loss of olfactory impairment, and that can be caused by things like neurodegenerative diseases such as Alzheimer's, such as dementia, such as a traumatic brain injury, something along those lines. And we all know the importance of olfaction and what it's used for. So it's really vital to the perception of our experiences in daily lives. So lots of good things: food, drink, pleasant smells, smelling our partner putting on perfume, having a diffuser with essential oils in your room for a good scent. But it's also used to detect bad scents, like things like be socially aware that like you have body odor, smell bad smells, or a dirty diaper of your child, or perhaps even more importantly, the ability to detect things like smoke from a fire or spoiled food or toxic fumes. And so it's really important kind of how we function through our daily lives. And we know that olfactory dysfunction, or the loss of the sense of smell, it's incredibly common. It ranges anywhere from 1.5 to 25% worldwide. And I think the body of data out there suggests that it's way closer to 25% than it is 1.5%. But some of these population level studies are pretty tough to figure out based on the heterogeneous way that olfactory assessments are carried out, specifically the use of self-report. Again, that's not really super accurate. So there, in many cases, there haven't been broad tests of smell, like psychophysical dysfunction, like there would be for hearing or vision, something along those lines. We also know a really nice study from Rod Schlosser and Zach Soler down at the Medical University of South Carolina, that olfactory loss and aging kind of go hand in hand, and they are some may even say inevitable. But all subdomain scores, they decrease with age, generally speaking. About 40% of individuals greater than 65 have some level of olfactory dysfunction. By age 80, about 2/3 of the entire population has some degree of olfactory loss. The implications of olfactory loss, we know that in comparison to other sensory functions like vision and hearing, that the sense of smell is oftentimes, it's relatively overlooked, and certainly it's understudied. Again, though, I think that there's important patient and population level considerations for those otolaryngologists on the meeting right now. Certainly, we know that managing somebody, for instance, during the COVID-19 pandemic, or even seeing in our clinics now, that there are dramatic consequences at a patient level on the loss of sense of smell. And I've been happy to see that there's been an increasing emphasis and structure across the global community to champion the loss of sense of smell, and some grassroots organizations that are working on combating this important problem and raising awareness of olfactory dysfunction. But we also know, in addition to just patient disruptions, that olfactory dysfunction, there's a huge body of evidence that show that that demonstrates that the impaired sense of smell is associated with perturbations in your eating and your nutritional status. It again decreases quality of life. It is associated with incidents of depression and anxiety, and this is great population level data over long periods of time. For instance, Jay Pinto has a study over 15 years, and he shows that the sense of smell seems to be maybe even perhaps a driver of the onset of depression, and not the other way around. We know that a loss of sense of smell is associated with decreased cognitive function, and there have been several really interesting studies over the past decade or so that have shown the association between loss of sense of smell and the overall increase in mortality. We're seeing this now more and more in mainstream media. Big pieces like in the New York Times talking about loss of sense of smell. We know that it disrupts our ability to eat and drink, or to even, in the States here, we just passed Thanksgiving. It's actually the joy of smelling the turkey cooking in the oven and the preparation of the food, perhaps even more so than eating itself. There's been there's a couple of memoirs, one from Stanley Tucci, who's an Italian-American, speaking about his love with food and his ability to smell and taste, and how that was disrupted by being diagnosed with head and neck cancer and the associated treatment. And Grant Achatz, the famous Michelin-starred chef from Chicago, describes a similar experience. So there is increasing awareness of this. As I mentioned, that olfaction and decreased olfaction, it's a bellwether of mortality. That is, it is an independent predictor of mortality that is independent of things like neurological, cognitive, cardiovascular function, things that we automatically assume in the lay public in our basic understanding of medical knowledge. Those are the things that will be related to your mortality. However, again, going back to Jay Pinto and several other really nice high quality publications, authors have demonstrated that olfaction is associated with mortality in a dose-dependent fashion. So increasing, worsening sense of smell is associated with increased olfaction. And actually, the really compelling studies is that the sense of smell is actually a better predictor of mortality than some other chronic conditions like heart failure, lung disease, cancer. These are highly compelling population level data. So great data of nationally representative studies that demonstrate that there's something here and something important, and they're fun to read. If you haven't taken a look at them, I think it's something worthwhile to take a look at. And so with these thoughts in mind, my question is, how the heck does that happen? What's going on with the sense of smell that it can actually predict our mortality? And so my question is the sense of smell, is it an indicator of your resilience? And so is olfactory dysfunction or loss of sense of smell associated with reduced resilience? And so that brings in the concept of frailty. Now, frailty, this is another key slide here. So frailty can be measured in a number of different ways. And that's one of the issues currently in frailty research, is that there is a wide variety of ways to define frailty. And so what is frailty? Frailty can be defined in one of two basic kind of broad ways. The overarching theme is that it is a concept that assesses somebody's biological age rather than their chronological age alone. So it takes in a whole bunch of different factors and shows how resilient or lack thereof somebody may be. So when we talk about, a good-looking 90-year-old, you kind of know it when you see it, and you say that that person is really strong and they're really cognitively intact and they're physically fit. But I'm sure that plenty of us know 60-year-olds who have had a harder life, who you look at them and you say, wow, that person is really frail. And that's kind of the concept that we're talking about here. So first off is the frailty index, which is really just a deficit accumulation model, meaning that it's a overall proportion of signs, symptoms, disease, and disabilities that can accumulate as a way to kind of justify that there's increased risk of adverse outcomes for a patient. So more simply put, this is making a list of conditions like being overweight, having diabetes, having heart disease, having cancer, and that person is likely not as well to respond afterwards. Hey Puya, I got a question. Am I on? Are you seeing presenter view?
I'm having problems to hearing from your side.
Are you? Can you hear me now?
Like I can't hear your voice.
No? Huh. Where'd it go? I can hear your voice just fine.
I don't know.
Let me see.
Can't hear your voice.
I didn't change anything over here.
Tell me if you hear me.
I hear you just fine.
Yes, but I can't hear you.
Understood. How's this?
Nope.
How's this?
No, unfortunately, I can't hear you. Try to log out and reconnect and see if it does work.
Cool.
Perché la signora sta in uno?
La devono mandare su adesso.
Ah, parte?
Sì.
Ah, la porto su.
I'm sorry, we having some issues. Nicholas will reconnect in a minute. Here we are. Let's see if the connection reestablished, if we can work with this. Nicholas, do you hear me?
Hey.
I can't hear you again.
No? Yay or nay?
I can't hear you. I mean, I can see you, but I can't hear you. Still.
And this doesn't work.
And I'm also asking, but nobody can listen to you even in the social media platform. So yeah. I think that what we should do now is, if you don't mind, and it's better to have it redone and reschedule the talk, so we will be able to reconnect the whole speak and the presentation. If it's okay for you, of course. I rather would be enjoying the whole talk instead of a part of it.
Yeah, yeah. Where did it go?
Nothing. I can see you moving your lips, but I can't see you. So I don't know. No, lately, it was like 5 minutes ago. So yeah. We were at the phenotype slide. Do you mind if we can rearrange it?
Yeah, we can.
That's the only thing. I can read your lips, but I can't hear you. Now, even if you disable and re-able and reconnect. All right. So hope you don't mind. We will reschedule it. I'm sorry, we're having some technical issues. Hope you don't mind. We will get it back at you, and we'll send you some information in regards to the rescheduled talk. And thank you. I'm sorry, Nicholas, for having this problem. I'm pretty sure there's something that we can manage it very soon. But instead of wasting our time right now, we will reschedule it. We'll have it again. Thank you for watching, and we will send you a message. You can see our social media platform, and we will reschedule the talk. Goodbye, everyone.